and welcome back to the Life Stages Theater. Our next session of the day is Choline, an important addition to prenatal supplements to optimize child mental health, presented by Dr. Camille Hoffman, Associate Professor, Maternal Fetal Medicine at the University of Colorado, Departments of Obstetrics, Gynecology, and Psychiatry. Prenatal choline and folic acid supplements have compelling evidence for improving child neurodevelopment and preventing potential mental illnesses, including schizophrenia, bipolar disorder, and autism. This presentation will provide an overview of existing data on the importance of these supplements during pregnancy, critical periods of fetal development and dosing, and their role in promoting normal fetal development despite avoidable and unavoidable maternal and environmental risks. Without further ado, Dr. Hoffman, you have the floor.
Thank you very much, AJ. I'm excited to be here and talk about a topic that is relevant to all of us, whether we're having children, or whether we have grandchildren or nieces and nephews. So I'm going to talk about our work on choline as an important addition to prenatal vitamins. So I know this is the infant health session. However, this also applies to prenatal. So I have no disclosures or conflicts of interest. Any supplement that I'm going to mention, either we pay for as part of our studies or are simply supplements that I recommend to patients because they're easily accessible in my area. This research is supported by the National Institutes of Health as well as a Colorado-based Institute for Children's Mental Health in Aurora, Colorado, and the Brain Behavior Research Foundation, who are based out of New York. So mental illness and mental health development have a similar body of literature, albeit not as robust as other ideas and concepts related to the developmental origins of health and disease, or DOHADs. So a group out of Switzerland published this figure several years ago, which kind of highlights the notion that our mental health is also programmed, or the trajectory is set during fetal life as a confluence of our genetics, maternal factors and exposures during pregnancy, and then environmental factors that can influence us along the path of our entire life. So we know that genetic and maternal exposures prenatally can result in early findings such as brain malformations, miscarriage, and early pregnancy loss. That intrapartum or labor and delivery factors can adversely influence the fetal brain and result in cerebral palsy. That multiple factors, some genetic, some exposure, some unknown, can increase the risk for autism spectrum disorders in early childhood. And then that many of the mental illnesses that afflict our societies manifest in adolescence and early adulthood, such as schizophrenia, depression, anxiety, bipolar disorder. But even as far out as becoming senior citizens or later in life, early life influences that affect the fetus can ultimately manifest in conjunction with environmental exposures over the preceding decades as Alzheimer's disorder and Parkinson's. So we know that so much of the way that our brain health and development will progress is influenced by these early exposures. And really the factors that have the greatest impact on child brain development are illnesses and infections that affect the mother and result in an immunologic or cytokine response. So the COVID-19 pandemic has been a prime example of an infectious exposure that we're concerned about as far as how it could influence fetal brain development. Alcohol, tobacco, and cannabis or marijuana use. Nutritional deficiencies such as folate or choline deficiencies. Psychosocial stressors, which can result in both inflammatory responses in the mother as well as higher cortisol levels and exposure of the fetus, and then psychiatric diagnoses. And these interact with genetics and with obstetric complications to change the trajectory for the better or the worse. So we know that the prenatal brain starts as as we all do, with 2 single cells, but that we think in terms of brain development as operating systems that once installed can't be uninstalled, but can only be modified. So if we think about early second trimester, so it begins around 14 weeks, as operating system 2, during this phase of fetal brain development, there is a copious expression of the CHRNA7 gene, which makes the fetal alpha-7 nicotinic acetylcholinergic receptor. It's primarily stimulated by choline at this time, and having enough choline around is what facilitates more expression of this receptor. During this time, another important point to make is that GABA, which is a neurotransmitter that we think of as soothing, is excitatory. And then the fetal development proceeds. Another couple of operating systems are installed. And then in the 3rd trimester, we think about OS5, just as the name that we've given it to explain the way that the brain develops. But again, CHRNA7 appears here. Alpha-7 nicotinic receptor expression is more abundant. And during this time, GABA needs to become inhibitory, as we know it, and as it should be for the rest of human life. But in impaired states, it fails to do this, and so continues to be excitatory. And that is the root of many mental illnesses, because GABA then cannot function as soothing or inhibiting synapses. It remains excitatory. And the problem is that once this is installed, we can't undo it. Once a fetus is born, there's so much acetylcholine around that it becomes the predominant neurotransmitter, and choline can't really change the way that these receptors function at that time. So really, fetal life, especially during the 2nd and 3rd trimesters, are the critical time period for this transition to occur. So what are causes of choline deficiency, and how can this influence how this brain shift and operating system layout works? Well, we know that there are some individuals with gene polymorphisms. The PEMT one is an example that is associated with schizophrenia, but genetic polymorphisms can be one way that the alpha-7 nicotinic receptor fails to function properly in conjunction with choline. Dietary deficiencies are more common. There's a tremendous amount needed during human gestation for cell membrane synthesis, as single carbon metabolism and DNA methylation, and as the cholinergic agonist, which will subsequently be replaced with acetylcholine once a fetus becomes a newborn. And then maternal stress. High cortisol levels are known to lead women to sequester choline for their own use in their livers and impair transmission to the fetus. And in North America, we know that 25 to 50% of women fail to reach optimal choline intake, compounded with these other potential issues, and becomes a deficiency. So just to give you a sense of this interplay between choline and cortisol, a group out of New York looked at these 2 types of levels, choline and cortisol, in women, pregnant women, in umbilical cord blood at the time of birth, and as far as its expression in the placenta. And they compared 2 groups. One was a group of women who received 480 milligrams per day of choline during the 3rd trimester. 480 milligrams approaches the American Medical Association recommended dose of 550 milligrams. But then they also had a group who received 930 milligrams per day. And what they found, even in 2 groups that were supplemented, were that the group who received the 930 milligrams per day had higher, so the moms who had a higher choline intake had fetuses and placentas that had decreased umbilical cord cortisol levels. So in this way, choline presumably buffered the fetus from more cortisol exposure. But there were no differences in maternal cortisol levels. And then they took it a step further and looked on the bottom two figures at placental corticotropin releasing hormone. Placental CRH is a well-known form of CRH that, unlike pituitary CRH, is upregulated over the course of pregnancy. So they found that gene methylation, so suppression of PCRH, was increased, which led to decreased expression or gene transcription of this hormone in the group who received a higher dose of choline. So two examples, or a stepwise example, of how choline supplementation at a higher level buffered the fetus newborn from adverse effects of cortisol or overexposure to cortisol. And then this is just a list of some other studies who have looked at prenatal choline supplementation in doses that range from 600 milligrams to 900 milligrams, demonstrating with whatever measure that they chose to use improvement in child neurodevelopmental scores or reactivity or EEG studies. So to kind of very briefly summarize in one slide, human trials of prenatal choline. One study found no difference in 5-month cognition of the newborn in relation to maternal choline levels, and that study used less than 400 milligrams a day, similar to the study that I just showed you in the 450 milligram group. Most observational studies have associated higher choline levels or higher choline intake, depending on the way that they measured it, with improved child cognition through the first 7 years of life. And most importantly, no study has found any adverse effects of choline supplementation during pregnancy, with the maximum tolerated dose of 7 grams, which would be equivalent to about 49 grams of phosphatidylcholine. Most of the pregnant women that I take care of, and I do have a clinical practice most of the time, would not be able to tolerate that volume of a supplement anyway. So it's not going to be a problem for us to supplement at the levels that we're using in trial. So wanted to just kind of give you a very brief summary of our data to date. We've completed a pilot randomized trial in about 2015. So most of the data that I'm presenting as far as 1- and 4-year-old child data are from that. And then we've more recently completed a larger randomized trial with the last mother delivering back in December, but still have many years of child follow-up. So our primary outcome of the randomized trial in general is a child behavioral checklist, CBCL score, at 40 months of life. The surveys that I'm mentioning today are the infant behavioral questionnaire, which we do at 1 year of life, and some data from the child behavioral checklist. And our study timeline is identification of potential participants before 15 weeks gestation. Then we do a 7-week lead-in to see if women are able to tolerate the amount of capsules that we are going to request that they take throughout pregnancy. If they pass that with 75% or more of capsules consumed, then they're randomized and consented at 16 weeks. And then multiple measures over the course of pregnancy of hair, blood, ultrasound, heart rate variability, and many psychosocial surveys. And then at birth, we see them for a study visit immediately postpartum, and then follow them and their babies out, starting at 1 month postpartum, out to 40 months. So I've condensed the multiple measures into the next 3 slides. But first, wanted to just give you a sense of what I'm talking about when I talk about the P50. The P50 is an auditory EEG that we do on newborns at 1 month of age. So they come in ready for sleep. Mom feeds them, and then we swaddle them and put the EEG pads on their scalp. And then they go to sleep, and they're played a snapping sound twice, 50 milliseconds apart. And that is what these figures depict. So on the left side of these figures are the first response, the EEG, the auditory response to the first snap, where you can see a little bump up and then a dip. And then the second frames are different. The top one is an infant who was treated with choline over the course of fetal life at 1 month. And you can see that the peak or amplitude of the peak on the second sound is markedly lower than the first frame versus the bottom. And I'm sorry that I don't have my pointer doesn't work. So the middle section where the two peaks are similar in amplitude. So that is kind of a failure to suppress the second sound or a failure to gate. And if we think back to GABA becoming inhibitory versus excitatory, this is what you see. And actually the bottom figure is an adult example of a P50 comparing a normal control to an adult with schizophrenia, and you see the same. You see in the control subject box on the left, a peak in amplitude, and then the second sound is completely almost suppressed. But in a patient with schizophrenia, two very similar peaks, so a failure to inhibit this or gate the background noise. So to skip for 1 second forward, the choline administration that our study participants receive are 900 milligrams times 8 capsules, so 7,200 milligrams of phosphatidylcholine to try and achieve somewhere between 900 and 1,000 milligrams of choline absorbed per day. We have an identical placebo capsule. It's corn oil. And as I mentioned, we do a 7-day capsule trial before enrollment. All women who are enrolled in our studies also receive dietary guidance on choline-rich foods. And as I mentioned, our larger randomized controlled trial finished with the last birth in December, but now we have 4 years of baby follow-up. And for anyone who's interested in more information, one of my senior mentors, Dr. Bob Friedman, created this prenataldoctoradvice.com that gives you all the information on choline background that you could ever want. So to talk through our data, these data are from the pilot randomized controlled trial, where we found that choline not only improves the newborn EEG, so improved auditory gating response, but that this improvement was also correlated with the child behavioral checklist at 40 months of age. So the upper figure is demonstrating in both low and higher risk mothers that prenatal choline enhances P50 inhibition at one month of age. And then the bottom figure is demonstrating that in those babies who had a more advantageous P50, that this is predictive of 40-month-old behavior in the child as far as withdrawal symptomatology, attention, and total problems. Then we looked at infections and a couple of other adverse exposures that we know can be detrimental to fetal brain development, and found that prenatal choline also enhances P50 inhibition in women who have reported some kind of infection during pregnancy. So a urinary tract infection, a respiratory infection, a sexually transmitted infection, it doesn't really matter. It's more the inflammatory response and the cytokines that are the offender of fetal brains. And maternal choline levels, as they increased at 16 weeks gestation, appeared to right that P50 inhibition that we otherwise saw in women with lower choline levels, and that's the top figure. And then the bottom figure correlates maternal choline levels at 16 weeks gestation and the infant behavioral questionnaire at 1 year of age. And again, you can see the blue line are mothers who reported no infections in the early second trimester, versus the red line are as choline levels increased at 16 weeks gestation, that infant regulation at 1 year of age also improved. Very similar findings for cannabis exposure. So our study is based out of Colorado. Colorado was one of the first states to legalize cannabis medically and recreationally. So whether we like it or not, we have a grand human experiment going on as far as pregnancy and cannabis use. So we had women who reported cannabis use, sometimes stopped when they realized they were pregnant or by 10 weeks gestation. But a number of our moms who were enrolled in our Trial also reported continued cannabis use over the course of pregnancy. So we grouped them by no cannabis use during pregnancy, cannabis use up to 10 weeks gestation, that's the red, that's the green line, and cannabis use up and beyond 10 weeks gestation throughout pregnancy. And had really similar findings that on the P50 at 1 month of age, mothers who used cannabis but had higher choline levels at 16 weeks appeared to buffer the negative impact, and their babies' P50 studies appeared similar to moms who had either stopped using cannabis or didn't use cannabis at all. And then when we looked at 1 year at that IBQ regulation measure, very similar findings where mothers who continued to use cannabis past 10 weeks gestation but had higher choline intake and choline levels at 16 weeks gestation had infants who appeared similar to those who had had no cannabis exposure or who for whom it had stopped at 10 weeks. So we didn't go out to go message, okay, well, go ahead and use cannabis during pregnancy and just take your choline. Like we do with alcohol in the United States, we still recommend it against its use. But now if we have a patient who unknowingly was pregnant and was using cannabis, we have a way that we can try and help her with recommendations to improve her baby's brain development with choline supplementation. And this kind of summarizes all of that, a little bit more specific to the choline levels that we found are better and worse. So a 16-week choline level, maternal plasma choline level of over 7 micromoles is associated with improved outcomes. But you can see that there is a linear improvement because this goes up to, in these other slides, up to 12 micromoles. Versus lower choline levels across the board when you have an adverse exposure plus a lower choline level are more detrimental to fetal brain development. And then finally, we've started to look at more health disparities within our data. So same cohorts and trial participants, but we've, in efforts to join the work in the United States regarding black versus white health disparities, we know that we have 2 major ones in obstetric care. One is preterm birth, and one is maternal mortality and infant mortality. So when we look at our data, one, we've realized that African American women have higher cortisol levels that we measure in hair earlier in pregnancy than our white non-Hispanic participants. And we know that cortisol and choline interact poorly or well, depending on the levels from slides that we already saw. So we looked in our population and found that higher maternal cortisol appeared to decrease maternal plasma choline levels at 16 weeks in our African American participants versus our white non-Hispanic participants. And furthermore, that higher 16-week plasma choline was associated with an increase in gestational age in African American women, where it didn't really matter for our white non-Hispanic women. So I'm certainly not going to claim that plasma choline or prenatal choline is going to also fix preterm birth. But one, in the United States, African American women have double the preterm birth rate of white women. 2, we know it's multifactorial. 3, we know that stress and cortisol play a role. So if choline can moderate some of that disparity, we're going to pursue it. We're happy to investigate that further, and we're hopeful. And this is just looking at gestational age at birth. Preterm birth is defined as birth before 37 weeks, so 37 weeks and beyond is term. And then at the different groups, black women who received placebo in the trial, black women who received phosphatidylcholine supplementation, and then white women in the same 2 groups. And you can see easily a difference in gestational age at birth amongst those groups. So our group and other groups were featured in Science Magazine a couple of years ago, citing things that can be detrimental to prenatal health as genetics, serious second trimester infections, preterm birth, which is also correlated with adverse neurodevelopment and birth complications. And things that can improve these outcomes include choline and good prenatal care. So we know that prenatal choline likely improves cognitive function well into adulthood. Maybe it prolongs gestation, and maybe for some individuals this is part of how their neurodevelopment can be impaired if they were born too early. And that it decreases the risk of impaired neural programming and development in relation to schizophrenia, ADHD, Down syndrome, fetal alcohol exposure, and from our data, prenatal infections and maternal marijuana or cannabis use. In our studies, we aim for 900 to 1,000 milligrams of choline. As I mentioned, we use Phoscol, a phosphatidylcholine supplement that we pay for by the study. Our study is not sponsored by this brand. The upside is that more women, in spite of gene polymorphisms or microbiome differences, can absorb choline in this form. The downside is that it's about $1,000 per pregnancy, which is expensive. And so these are some of the other types of choline supplementation that we can recommend that our patients can access less expensively and more easily. These are foods, and this is on that prenataldoctoradvice.com website, but the most choline-rich foods are eggs, salmon, and liver. American women hardly ever want to eat liver in pregnancy, but it's advisable if they do. Another bit of info on choline doses of different foods. I think I already mentioned this, but our AMA, American Medical Association, recommends an evidence-based amount of choline, and that has come out as 550 milligrams, although our group and others feel like 900 to 1,000 is better, and we have data that improves outcomes. And if we think about the folic acid story, where folate, when supplemented and fortified in foods, reduce the risk of open neural tube defects by up to 50%. If we could achieve a similar impact with choline and mental illnesses, that would be a huge population impact. So takeaway points, thank you AJ for giving me a couple more minutes, are that maternal choline buffers the fetal brain from things that women can and cannot avoid during pregnancy. This is a primary prevention strategy for the fetus. It's not a mitigator of mental illness. It can prevent mental illness. We just need time to follow these individuals out into early adulthood to be able to demonstrate this more strongly. And improved health for society by reducing the risk of mental illness and even improving neurodevelopment, but not to the extent that that person would have ever had a formal mental illness diagnosis, still leaves two people thriving more and struggling less. Thank you. My email address was on the very first slide.